This podcast is sponsored by Orchid Live. Orchid Live is a specialist occupational health software used by a number of SOM members to run every aspect of their occupational health operations. They hold healthcare records for over 1 million UK workers and work with both in-house OH teams and OH providers. You can find out more at orchidlive.com. Hello and welcome to the SOM Podcast. I'm Steve Randall and I'm joined on this episode by an esteemed panel of guests as we talk about fit notes. Let's welcome our panel.
My name's Toni Hazel. I'm a GP in a deprived area of North London and I've got a portfolio role with various interests in education.
Hi, I'm Greenberg. I am a consultant psychiatrist. I'm based at King's College London. I spent 23 years in the armed forces and I'm currently the president of the Society of Occupational Medicine.
Hi, I'm Lara, Shemtob, GP and occupational health physician, and the fit note is actually why I got interested in occupational health in the first place.
Hi, I'm Bob Gallagher. I'm a working GP. I'm also an occupational health doctor, and I'm the medical advisor for Social Security here in Guernsey.
Well, welcome all of you to the SOM Podcast. Toni, I'm going to come to you first of all. Perhaps you can give us an overview of how fit notes work in the real world, in an NHS practice for a GP. How does it work currently?
So a fit note is done electronically and we can do them as not fit for work, which means, just as it says, not fit for any work, or we can do maybe fit for work, which brings up a comments box where we can say fit for office work but not fit for manual labour, or might need a phased return to work, any particular comments that we want to make.
And of course, historically, it would have been a sick note and it was a very different system. And this is a relatively new thing, isn't it? Has the situation improved, would you say?
Yeah, so it changed some years ago from being called sick note, I think it was the old Med 3 form, to now being called a fit note, although patients all still ask for a sick note and I think probably will forevermore. One of the big changes was the expansion so that other professionals could write them, nurses, physiotherapists, a variety of other professionals. And so really the big change since they moved to being called fit notes from sick notes is this option of maybe fit to work. So it's not just an all or nothing. You can put in parameters under which the patient might be able to work.
Brilliant. Thank you for giving us that overview. And I mean, obviously there are other ways of doing things. Bob, let's bring you in. And although Guernsey, of course, is under the UK umbrella for lots of things, you operate a different system there in terms of the healthcare that's provided. So how are things different in Guernsey in your practice to how Toni has described things on mainland UK?
So Guernsey is outside of the NHS, so it's a private primary care healthcare system. And we have secondary care. Once people get referred into the secondary care system, then the states pick up the bill for all that. We do approach things differently here. So working as a medical advisor, one of the things we've looked at is the process of how people get sickness certificates and how we manage that and how we try and manage that most effectively. And as the medical advisor, what I'm trying to concentrate on is improving the health of the working population first and foremost. And then part of that is actually looking at the sickness certification process and the sick note, which is what we still call it, and how do we manage that effectively. We want GPs to be having the healthy work conversation. You know, how is work impacting on your health? How is your health impacting on work? And actually encouraging GPs then to be the people who are starting the conversation and using their GP knowledge rather than formal occupational health training at this point to have those conversations. The next stage we're going to do is and it's a process, is then go, right, what is the formal training we need to give to our GPs so that they are more empowered to have those conversations. If you start with the process that work is good for your health, and actually having this conversation is going to be a good thing to be doing for the patients. But this is not instantly transferable to the UK because we are a completely different system, the way we operate, but it should be of interest to people outside of the UK. It's different. It's worth considering. We have a clear plan of communication, and over the next 12 months, I'll be doing some training for all the GPs on the island. We'll be actually doing a lot of education to employers so that they understand there is a thing that people can be signed off as in not fit for your job, but fit for some type of job. And we will be also trying to target the education to the patient population as well, to say, have this conversation with your employer and also with your GP about what you can and can't do. Where it gets to will be fascinating, I think, as a comparison to what else is going on.
Toni, do you want to pick up on that? And there are some things there that you'd think, well, if only we could do them here, but there's always going to be the constraints within the NHS of what government is prepared to fund.
So, yeah, it's really interesting to hear about how things are done differently and in different systems. I think we are limited in the UK just because resourcing is so much less. So we get a fixed amount to look after a patient for a year. It's not a huge amount. And of course, we do have conversations about health. So there are some medical presentations where it's directly relevant. If someone's got eczema on their hands, I'm very interested to know if they wash up for a living, or if someone has asthma that may be affected by their work. And there's various others of that I think would be well within the remit of the normal GP taking a normal history. I think the problem is when it comes to the idea of the GP having a more in-depth conversation about work and health. From my perspective as a GP, I'm not sure that I feel I have the training to do that beyond the sort of common sense knowledge of being a human being and a doctor and a person who has had various jobs in their time. And from the resourcing point of view, we just simply do not have the time. But if there were resourcing available, that would be really suitable for a GP with an extended role, a GP WER network. So there are GP WERs in a variety of different clinical areas. I know quite a lot of GPs who have an interest in occupational health and have qualifications. And the idea that in every area you had a GP WER hub for work and health. And so if the registered GP felt that this patient could really do with a bit more of an in-depth conversation about how their health and their work interact, they could refer there. That would be absolutely fantastic. But it would need to be resourced. Whereas when people say, oh, you know, the GP is ideally placed to have these conversations, the general feeling is that often has to come out of our existing time. And no one ever wants to answer the question of what else should we stop doing in order to do this thing?
Absolutely. Neil, sounds like there might be a role here for occupational health to get involved.
Well, absolutely, Steve. I mean, so this whole discussion so far has been about people's fitness for work. And of course, that is exactly what occupational health professionals do. You know, they are the work and health experts. So I think in the short term, if you have a patient with an acute health problem, for instance, they've had a heart attack or they've had a stroke, I don't think necessarily you need an occupational health physician to make it clear that that person's not fit for work in the short term. But when things become more chronic, or if people have perhaps lifelong disabilities, then I think absolutely there is a place for sure for occupational health professionals. And I think in some ways it's rather unfair to ask GPs to be making the decisions for the state when actually the GP's job is to try and look after their patient. And, you know, occupational health professionals are pretty used to feeling that tension between what an employer wants and what an employee wants and having an independent view. And so I think that's the important thing that occupational health professionals can bring. And just as Toni said, what would be fantastic is if there was some capability which had occupational health at its heart, which would enable GP practices to refer to, so that facility would be able to make, you know, good evidence-based decisions. And I think the other thing that we need to think about as well is, of course, GPs often don't know a lot about what someone's job is. I think that if someone says, I work in security, a GP might think they stand at Tesco stopping someone stealing things. Well, in my world, I'm ex-military. Many of the people who work in security carry guns and are out in war zones. An occupational health professional would go about finding that information out. So there is absolutely a role for occupational health to be a bit more central to this whole fit note discussion.
And Lara, do you want to pick up on that? And what's the evidence that you've seen, and, you know, what's your experience?
Yeah, I mean, I completely echo everything that's been said in terms of the current barriers for GPs in executing on fit notes. And what we know from the data is that since the fit note was introduced, over 90% of the time, we are not using the maybe fit for work section in general practice, i.e. it's basically being used as a sick note, even though the policy change was to try and open up more optionality. So the barriers that we've discussed are time in consultation, positionality of GPs, professional expertise of GPs, which is not the same as an occupational health physician. And I think the hacks that we can use in practice, and none of this is about GPs working harder. But things that I find helpful include if a fit note comes as a second issue in a consultation, which, as everyone's mentioned today, it very often does, seeing if we can book it into a separate consult for a bit more time, because it's never going to be an easy conversation in the final minute or less of a consultation. The other hacks are writing in the maybe fit for work section in the free text, if you're worried that this is a complex case, then refer it saying to the employer, consider occupational health referral or recommend occupational health referral. So leveraging that option as well. But I think the points that have been made today around the policy side of things, both from Bob's experience and what Toni and Neil were saying in terms of getting some local occupational health expertise that practices can refer out to or use locally, obviously is a much more robust long-term solution.
I think that's really interesting what you said, Lara, about, I think you said 90% are just done as not fit for work. And I'm always fascinated. I heard a similar stat a few years ago, because I'd say about maybe 2/3, 3/4 of my fit notes are maybe fit to work. I really value that. And I probably put similar things very often. I often write, could occupational health be involved? It's often around the distinction between manual labour and non-manual labour. It's often about my patients needing to access either English classes or things like basic computing skills in order to be able to work. So I absolutely do think that we should be doing more maybe fit to work. The point you made about booking into another appointment to discuss it in depth is exactly what I meant about us not being resourced, though, because we only have a finite number of appointments. So if you take up an extra appointment to discuss the fit note, someone's not getting that appointment for what we are there for, which was to discuss their problem. So that is exactly, unfortunately, what we can't do unless a funding mechanism comes in whereby we can code that this is an appointment specifically to discuss the fit note, and that coding can allow some extra resource to allow the appointment to be replaced. But short of that, you won't see GPs offering a second appointment really just to discuss it, because it wouldn't be fair on the patient who's not getting that appointment to discuss their problem for the first time.
So I completely agree. So when you asked before, do people make a specific consultation appointment to discuss the sick note? That doesn't happen an awful lot. But I think that's where we will end up in Guernsey. Over what period of time, I'm not quite sure. And again, that should be really interesting, that if we can train the GPs effectively to have that conversation, and they then, people are encouraged to have this specific appointment purely to talk about work and what needs to be done to help them get back into work, then I think that could be really useful, because I'm not aware of other sorts of, we're going at it very positive. You go, we think this is the right way to progress things for our community. And it might work, it might not, but we're going to try that.
Yeah, and I agree. There's so many challenges with being boundaried around consultations and where we can offer follow-ups and where we can't. And it is really difficult to have a conversation about this squeezed into another complex health issue, as well as challenges with the narratives around fit notes. So as you mentioned at the start, Toni, most patients still refer to them as sick notes. And even trying to get over that communication thing of, maybe fit for work is an option. Wait, but this is a sick note, isn't it? So that whole thing can also take out a lot of time. So as usual in general practice, time is one of our biggest challenges.
Yeah, I think the thing that perhaps is some hopefully light at the end of the tunnel is that the Keep Britain Working review. One of the things that it aims to do over its many years of implementation is to address the fit note. And the Society of Occupational Medicine, we've met with the Keep Britain Working team many times, and I think very sensibly although they want to make changes, they are not going to make changes until they have a plan. Stopping the fit note without an alternative would be a catastrophe. And so what we hopefully the output of this conversation is, I think we're all agreeing that some occupational health expertise is needed. We can't ask GPs who are patient focused to act on behalf of employers, and occupational health professionals will sit in that middle ground. So hopefully going forward, we will be able to influence the way that the UK does this better.
Yes, I completely agree. You need the right person with the right skills. And it's been mentioned a couple of times. I think Neil used the word tension between occupational health physicians and employers. And Lara talked about these sometimes being difficult conversations. And I think that's another issue. We look after the whole family. So if I'm having a conversation with someone about a fit note, and maybe my opinion about whether they're fit to work is different from their opinion, I've still got to carry on looking after them. I've got to see them the next day when they bring in their sick baby, or they come in with their elderly mother, or whatever. And these are very difficult conversations, I think made more so because we don't have the occupational health knowledge, because often there aren't the jobs out there maybe that are as satisfying as we would want them to be for our patients, because our patients come to us with all sorts of past experiences, with issues of who in their household has or hasn't worked in the past, with the fact that they haven't worked or they haven't got any qualifications or they've just come out of prison. And so it's really very complex. They are difficult consultations. And I think GPs are also concerned that if a complaint arises because of such a consultation, they can be quite time consuming to deal with. A patient can complain to multiple places, to the practice, to NHS England, to the GMC, to the local MP. I have been aware of cases where the practice has ended up answering the same complaint, which in this case had no merit, 4 times because it was made to 4 different bodies. And I think GPs do feel quite unsupported when that happens. So all of that tension and difficulty and wanting to preserve the doctor-patient relationship, because we're going to need it the next time they come in with a medical problem and we want to be their ally, I think all of that contributes to the difficulty.
Well, we could talk about this for hours, but we are running out of time. So before we finish, imagine you have the ear of Wes Streeting and the policymakers who can drive forward a wish list. If I come to you first, Bob, maybe from experience in Guernsey, things you are doing now that you would like to see the mainland UK being able to replicate or do in some sort of way, what would be on your wish list, or what would you like policymakers to consider?
I appreciate I'm in a really enviable position here because as a GP, I'm frontline seeing the patients. An occupational health doctor, I get that perspective. But as a medical advisor also, I sit in front of our politicians, in front of our senior civil servants, and I tell them how fantastic the GP service is that they have. And that's a general thing of going how good the GPs do generally in terms of keeping people out of hospital, managing complex conditions, deprescribing and all those things. That's where I start. But if we are going to help manage this, then we need to engage positively and proactively with a GP community that actually has open ears to, okay, what else can we do? But they're able to do this because we don't have the same pressures. When I work as a GP, patients who are registered with me will be able to see me on the week they want to see me, sometimes on the day they want to see me. And that's not because of the financial system, it's of population numbers and all that type of stuff. So promoting GPs and saying how fantastic it is an essential part of my job, and then trying to fit the job of supporting the GPs to be able to take on a bit of the occupational health thing is really important. What's really interesting is that we do have some GPs who've developed a special interest in occupational medicine across the 3 practices. And those people do perform a role of assessment of people on longer term sickness absence, of going, right, well, what else can be done to improve your health first and foremost? If it leads to returning to work or taking volunteering, that's great. But the point of them is often just, how can we improve your health?
Lara, you've heard Bob talking about what happens in Guernsey. What would be on your wish list? What would you want to tell policymakers?
Yeah, so I think the idea of some kind of accessible occupational health support for the general population, either through a GP with special interest or some kind of local structures, would be really valuable. And I think the government is doing lots in this space. So we'll watch this space. But one of the important things is this cannot be completely outsourced to non-clinical expertise. We're talking often about safety critical work, and we're talking about complex health. So I definitely think the clinical expertise needs to stay a part of it.
Toni?
Yeah, I absolutely agree. Firstly, on a systems level, we need to make sure that everyone in the NHS can issue fit notes. The bad old days where I'd get a discharge summary from hospital saying patient needs 12 weeks off work, sick note for 2 weeks done, GP to do the rest. I haven't seen that probably in a decade. But with my local medical committee work that I do as part of my portfolio, there are a huge amount of challenges to secondary care issuing fit notes. And that's really important, because if a patient comes to see me and says, well, I had an operation and they gave me a 2-week sick note, but I need a lot more, I don't know whether they actually do, because I'm not a surgeon and I don't know how long you need off after any given operation. And even if I do for that operation in general, I don't know whether that person's operation was complicated or straightforward, or if there are any other factors. So we need to make this available across the whole system. We absolutely need occupational health access for all. So when I'm talking to my patients, my heart slightly sinks if I'm having a work-related conversation and they say they work for, the local newsagent or something, because I know they're going to have no access to occupational health. Whereas if they work for the NHS or the council or a big multinational company, then they are more likely to have access to occupational health. And I really do think the GP with extended role is the way to go. We have a population of GPs out there who have this training, and quite a lot more, I'm sure, who would like to acquire it if there were jobs at the end of it. So they have the whole holistic approach that comes from being a GP, and then they have the occupational health role on top. And I suppose the final thing I would say is that there are various schemes, and they come and go, these schemes. You know, we refer to them for a few weeks and then we find out that they're full or whatever, that are meant to support people back to work. But what I often find is I refer someone and then I get a letter back saying, oh, patient was reluctant to engage, case closed, or patient was nervous about starting work, case closed. Most people who have been off work for some point are going to be reluctant or nervous. And I think if back to work schemes aren't able to engage over a period of time and try and help people through that reluctance and that nervousness, then they're probably not going to be terribly helpful, because I suspect the number of people where it's just very straightforward who will be referred to a scheme like that is going to be small.
Great, thank you. And Neil, you get the final word on this one. What do you want policymakers to know?
Well, I think I've been very heartened by what my three colleagues have just said. So the key points that I think I would want them to know is that, first of all, that occupational health expertise has to be front and centre, particularly for chronic health conditions. And that the point that I think really importantly as a psychiatrist that Toni just made is it's not about we must make people go back to work because that's what the state needs. It's actually good for them. Good work is good for health. And so actually as clinicians, if we can find ways to help even reluctant, nervous or concerned patients find a way to get back into work, then everybody wins. It's a win for the government, it's a win for the individual, and also it's a win for the GP, because hopefully they won't come back quite as often.
And that seems like a great place to end this conversation for now. Thanks very much to the panel and to you for listening. If you don't already follow or subscribe to this podcast, please do, so that you get episodes automatically in your podcast feed. And you can always find out more by visiting som.org.uk. This podcast is sponsored by Orchid Live. Orchid Live is a specialist occupational health software used by a number of SOM members to run every aspect of their occupational health operations. They hold healthcare records for over 1 million UK workers and work with both in-house OH teams and OH providers. You can find out more at orchidlive.com.